ไลด์สอนให้ผมส่งให้ใครได้บ้างอะครับทุกคนได้ยินเสียงชัดไหมเอ่ย
ได้ยินค่ะ
อ่าให้ผมกระจายสไลด์สอนไปให้ใครดี
เดี๋ยวหนูแปะเมลในแชตบ็อกซ์นะคะอาจารย์สักครู่นะคะ
ได้เลยครับ
อาจารย์เห็นเมลไหมคะ
ยังไม่เห็นเลยครับเดี๋ยวนะเอ่อมีเมลของเพื่อนคนเดิมอะส่งไปผมส่งไปได้ไหมเอ่ย
อ๋อคนเดิมก็ได้ค่ะ
ครับ
ได้ค่ะ
ส่งไปแล้ว
อาจารย์
ส่งไปแล้วครับทุกคนเห็นหน้าจอเนาะ
เห็นค่ะอาจารย์
โอเคอ่ามาครบกันหรือยังไม่งั้นจะเริ่มเลย
ครบแล้วค่ะอาจารย์
โอเคครับงั้นเดี๋ยวเริ่มเลยนะ Okay, the topic today is about the conduction system of the atrioventricular and the intraventricular conduction system. Uh, this conduction system would, if the conduction system have some abnormalities, they would lead to uh, bradycardia and bradyarrhythmic syndrome. So today I am going to talk about the fundamental of the cardiac conduction system. You need to know about how the cells could generate the impulse and could conduct the impulse. The epidemiology of bradycardia in the general population and how to approach the bradyarrhythmia through the 12-lead ECG. So the first things you need to know is the types of cardiac cells. There are two types of cardiac cells. The first one is the pacemaker cells, and the second one is the non-pacemaker cells. The pacemaker cells is the cells which is located in the sinoatrial node and the atrioventricular node or the AV node. These types of cells would lead to the generation of impulse of the normal heart. Um, and the second type of the cells is the non-pacemaker cells. This cell is the most common type of the cells in the cardiac. Uh, this consists of the cells located in the atrium and ventricle. Most of the cells in the heart are this type of cells. So a lot of mechanism of the arrhythmia and the arrhythmic drug would talk uh, would um, would talk about this non-pacemaker cells more common than the pacemaker cells. And now we are going to look into the normal conduction system of the heart. The impulse of the normal people would generate from the sinoatrial node or the SA node. And the impulse will go along through the atrium and into the atrioventricular node or the AV node. And then the impulse would spread into bundle of His and would go to the right bundle branch and left bundle branch and would spread into the ventricular muscle cells. This electrical impulse, you would be see all the electrical impulse into the summation of all of these along the conduction system into the 12-lead ECG in the on the right side below. And you can see in the right diagram, these are the action potential of the different location of the cardiac cells. In the SA node area and the AV node area, the conduction action potential are quite the same because these two are the action potential of pacemaker cell. But the other areas, the action potential is different. You can see that in the ventricular muscle cells in the gray diagram. Uh, and the left bundle branch cells, the action potential are quite similar because these are the non-pacemaker cells. So we are going to look into the action potential of the non-pacemaker cells which locate in the atrium and ventricle of the heart. The non-pacemaker cell have 5 phases of depolarization and repolarizations. The first phase is the resting phase or phase 4. These phases are caused by the are maintained in the negative state of the cells, which is around minus 90 millivolts. The ion channel which maintain the negative of the cells are the sodium channel and potassium channel that you can see on the green, the picture uh, on the slide, that which is the green color. This is the ion channel which maintain the resting membrane potential, this one. And when there's something trigger the cells, trigger the change of membrane potential into less negative of -70. This would lead to the opening of the sodium channel here and would cause the depolarization. The depolarization caused by the inflow of the sodium channel into the cells, which leads to the positive of the membrane potential to to the positive of 20 millivolts. Because the sodium channel is the positive ion, this would lead to the overall positive of membrane potential. This is called the phase zero of the cell. And after the phase zero finish, the cell would enter the phase one. The phase one, the phase one, the membrane potential are less positive. This caused by the outflow of the potassium channel. The potassium channel, which is also the positive ion, flow out of the cells and leads to the less positive of the membrane potential in phase one. And after the phase one, the cells would enter the phase two. The phase two, we call it the plateau phase. We call it the plateau phase because the potassium channel still open and the potassium cell still flow out of the cells. But in this phase, the calcium channel here is also open. But the positive of the calcium ion flow into the cell. This would balance the membrane potential and cause it to be plateau around positive around 5 to 10 millivolts. And after the cells finish the phase 2, it will enter the phase 3. The phase 3, we call it repolarization phase. In this phase, there is no inflow of calcium channel. The potassium channel still open. So the positive ion of potassium still flow out of the cell. This leads to the less positive until the membrane potential are negative again around -90 millivolts, and this uh, would end up in the phase 4 of the action potential of non-pacemaker cells. This impulse generation would lead to the pumping of uh, cardiac cells. So this is the non-pacemaker action membrane potential. Now we are going to look into the pacemaker action potential, or the SA node and AV node action potential. You can see that the graph is different. There is only 3 phases, not 5 phases, like the non-pacemaker cells. And the first thing I want you to recognize is that the phase 4 of the pacemaker cell uh, are the slope of the phase 4 much more the slope of the phase 4 comparing to the non-pacemaker cell, this slope. And the more the phase 4 has the slope, this would leads to easier of trigger the depolarization, and this would lead to the automaticity of the pacemaker cells. And also the phase 4 of the pacemaker cell was triggered by the inflow of calcium channel, not the sodium channel like the non-pacemaker cells. When the pacemaker cells enter the phase 4, um, the the resting membrane potential are trigger and become less negative at around -70. Then after that, the cells would be triggered into the phase zero or the depolarization phase. In this phase, the phase zero, the sodium channel would flow into the cells. This is the same. The phase 4 is the same as the non-pacemaker cells. But the phase 0 is the same as the pacemaker cells. But the phase 4 is different. The phase 0 used the sodium channel to flow into the cells and cause the membrane potential to be positive, around 20 millivolts. And after the phase 0 ends, the cell will enter the phase 3. The potassium channel would flow out of the cells, and this would lead to the return of the membrane potential into the negative stage. And after that, the pacemaker cell would enter the phase 4 again by the calcium channel. So this is the basic of two types of the cells in the heart. Okay, now we are going to talk about the incidence and the importance of the disease caused by the abnormal of conduction system. The first one we are going to talk about is the sick sinus syndrome, or the abnormal of the SA node. You can see from this graph the incidence of the sick sinus syndrome per 100 persons increased by the age of the patients. When the patients getting older and older, the SA node degenerate, and this would lead to abnormal function of the SA node and would lead to what we call a sick sinus syndrome or the abnormal of SA node. And this graph is the trend toward the future. The trend estimate number of incidents of sick sinus syndrome cases per year overall and by the age group. In this study was done in the United States, and they predict that in the future there would be more and more people experience the sick sinus syndrome. You can see that the incidence in the year 2010 are much lower than the year 2060. But this is just a prediction, but the trend toward this disease is increasing. And another conduction system abnormality that we encounter often is the AV node disease. The incidence of AV node disease, the incidence of complete heart block, which is the highest degree of AV node disease, the most severe was 430,000 in the year 2005. And the mortality of the complete heart block without pacemaker was 50% in 2.5 years and 68% in 5 years without pacemaker. This mortality is very high. So if the patient with complete heart block uh, were not put in the pacemaker, half of them would die in 2.5 years. And the average longevity in the patient with complete heart block without treatment is only 2.5 years. So what about the symptoms of bradycardia? Uh, Patients can have a lot of symptoms. There are two mechanisms that cause the symptom of the patient. The first one is due to the cerebral hypoperfusion. The blood cannot flow to their brain properly, so they would experience the symptoms. And the other mechanism is from the heart itself and from the from the feeling of some irregularity in the heartbeat. Uh, the symptom from cerebral hypoperfusion is For example, syncope, the patient may feel dizziness or vertigo because the brain cannot have enough blood. Some of them would experience easy fatigability or some dyspnea. And some of them would come to the doctor and told the doctor that they have some palpitation or they cannot exercise as before they have bradycardia, or we call it chronotropic incompetence. So how can we approach the bradyarrhythmia? First of all, we would recognize the bradyarrhythmia from the ECG. And after we see the ECG that this is the bradycardia or bradyarrhythmia, and we would localize the where where's the lesion of the problem, which location of the heart, the SA node, the AV node, or the other parts. And after that, we would investigate the cause of the arrhythmia. It would be from the degeneration of the heart, or it would be from other causes such as medication or from some infection or from coronary artery disease. And after that, we would manage the bradycardia according to the symptoms and according to the cause of the bradycardia. So the most important thing is to recognize the ECG. There is as like I said before, there's two important types of the conduction system abnormality or the bradycardia. The first one is the SA node disease. The SA node disease has two subsets. The first one is the impaired impulse generation, which means that the SA node cannot generate impulse. This is the disease which is in this subset is the first one is inappropriate sinus bradycardia, and the second one is sinus pause or sinus arrest. I will talk about it later in this lecture. And the second type of SNO disease is the impaired impulse conduction. This one is caused by the SNO could still generate the impulse, but the impulse cannot exit the SNO, cannot generate, cannot go along into the atrium. So this would also cause the bradycardia. Now we are going to look into the SA node. The SA node located in the right atrium between the superior vena cava and the right atrium junction. In the SA node anatomy, there is two areas. The first one in the red is the impulse generation, the impulse generator, and the second one is paranodal area. The impulse generator is the cause of um, impaired impulse generation. This is the abnormal of impulse generator. And the paranodal area is the cause of the impaired impulse conduction because the signal from the impulse generator cannot exit the area of paranodal area. So the conduction of the SA node is abnormal. This first one is the ECG of sinus bradycardia. You can see that the rate is so slow. The rate was around the rate is so slow, but you can still see the P wave. So you know that the impulse is generated from the sinus, but it is abnormal because it is too slow. So what is the cause of sinus bradycardia? The first one is from the impulse generator. The impulse generator, the normal impulse generator would generate the heartbeat around 60 beat per minute to 100 beat per minute. So if there is some abnormal of impulse generator to generate less beat per minute of the heartbeat, this would cause sinus bradycardia. And another type of sinus bradycardia is the abnormal of paranodal area, or the conduction the conduction of the impulse out of the AV node. So you can see that in the red, the impulse generator could still generate the normal heartbeat of 90 beat per minute. But the impulse enter the paranodal area in the yellow but cannot exit this area into atrium. It can only exit half of the impulse that was generated. So this would also cause sinus bradycardia. Or we can call this one the SA exit block. And this one is the ECG of the type 2 second degree SA exit block. Don't worry about the type of the SA exit block. I will sum up for you in the next few slides. So I am going to show you that this SA exit block, you can see that there's some group of the beats that could generate out of the SA node. Here, there's a P wave in front of QRS, and there's some drop of the P wave because some of the impulse cannot exit the SA node into the atrium, so it could not generate any P wave or QRS complex. So this is the SA exit block. The impulse generate from the generator. It travel into the perinodal area, and it would exit into the atrium. The this this is this is the normal baseline ECG on the first on the first row of the diaphragm. This one, the normal baseline. You can see that there's a constant P wave and the rate is normal. And if there is some type of SA exit block, this is the first type, the type 1 SA exit block. There is some progressive shortening of P wave here. The PP is 780 millisecond and 680 millisecond. And before there's some drop of P wave here. So this is the first type, the type 1 SA exit block. Type 1 second degree SA exit block. And this one is type 2 second degree SA exit block. You can see that there is some drop of P wave here. And also this one, the D one is not the SA exit block, but it's one type of the SA node. So I will talk about it later. So there is two types of second degree SA exit block. The first one is the type, I will speak about the type 2 before. First, the type 2, this is the type 2. In the red circle is the impulse generator. It generates the normal impulse of 90 beat per minute. And the impulse travel into the paranodal area. The impulse could only exit half of the generator. So it exits into 45 beat per minute. This is called type 2 second degree SA exit block. Uh, Again, this one is the impulse generator of 90 beat per minute. And the impulse travel into the perinodal area. But there is some progressive delay of the beats of the impulse in the perinodal area. Some are delay more than the others. So some can exit the perinodal area. Some cannot exit the perinodal area, and the timing of the conduction in the perinodal area is different between the impulse here. So you can see that the P wave is not regular. The P wave is progressive shortening, and then it is disappear. So you can see here compared to the ECG, here is the impulse generator from the SA node, which is not shown in the ECG because the P wave is the atrial depolarization. This would show only after the impulse reach the atrium. You can see from the first one that the impulse from the SA node is not that delay into the atrium. But the second impulse is more delay. And the third impulse is even more delay. And the fourth impulse here is blocked. So this would appear in the ECG like this. The progressive shortening of PP here. Here, this one is longer. This one is longer than this one. And this one is P wave. It is just disappear. This is called the type 1 second degree SA exit block. Here is the ECG of type 1 second degree SA exit block. This is the criteria that I have spoken before of the type 1 second degree SA exit block. Is the progressive PP interval shortening before the pause, and the PP interval length of drop beat less than the twice shortest PP cycle length. So what about the first degree and third degree SA exit block? This is the third degree of SA exit block is that there was no impulse allowed to exit the perinodal area. So you cannot see any P wave in the ECG. This is the third degree SA exit block. And what is the first degree SA exit block? The first degree SA exit block is um, the impulse generator and the conduction can still exit the perinodal area, but it is delayed. So you cannot see this delay in the ECG. You cannot detect the first degree SA exit block by the ECG itself. You have to do something. You have to investigate. Uh, you have to have a more advanced investigate to see this phenomenon. Um, so all of that is the SA exit block, the impulse generator, the impulse conduction abnormality. So we are going to talk about the impulse generator abnormality now. The first one we are going to talk about is the sinus arrest. The sinus arrest, as you can see in this ECG, is that there is no P wave at all. You cannot see any P wave. This means that the impulse could not generate at all from the sinus. The criteria of sinus arrest is that there is no P wave on the ECG equal or more than 2 second without the recovery of the P wave. So if you cannot see the P wave at all and you can only see the QRS, you can say that this is the sinus arrest. And this is the impulse generator abnormality. And another type of impulse generator abnormality is the sinus pause. You can see from the ECG that there is a pause here in the ECG without any P wave, but after that there is P wave recovering from the pause. This pause has to be more than 3 seconds, so you can call this sinus pause. So the sinus pause is that there is no P wave more than 3 seconds, but there is some recovery of the P wave in the ECG. So this is the sinus pause. The sinus pause is also the impulse generator abnormality, but it's not as severe as sinus arrest, because sinus arrest you wouldn't see any P wave at all in the ECG. And another type of sinus node abnormality, we call it tachybrady syndrome. You see that in the ECG there is a pause here. There's a pause here. And after the sinus pause, there's recovery of P wave. Okay, this is sinus pause. But after that, there are some tachycardia generate from not from the SA node, maybe from the atrium or from other part of the heart, because when the sinus node is not function properly, the heart is trying to generate the impulse from the other parts. So the impulse is fast and not coming from the SA node. This is called the tachybrady syndrome. This is one of the type of the SA node disease. So this is the SA node action potential for sum up again. Only the potential is the pacemaker potential with 3 phase: phase 0, phase 3, and phase 4. Okay. For summary, 3 types of SA node dysfunction is the sinus bradycardia, sinus pause, and sinus arrest, tachybrady syndrome. Uh, some of the textbook would add up the SA exit block as another type of sinus node dysfunction. Some of the textbook would put the SA exit block into the subset of sinus bradycardia. Okay, we finished with the SA node disease. Now we are going to talk about the second dysfunction of the conduction system abnormality, the AV node or the atrioventricular node disease. This is the AV node. The AV node is along the conduction system abnormality between the atrium and the ventricle. It is the junction of the atrium and the ventricle. If there is some block or some abnormality in this area, this would cause the bradyarrhythmia. For the subset of the atrioventricular node dysfunction, there is 2 types of the AV node dysfunction. The first one is the nodal block, this one. The block inside the AV node. And another type um, of the AV nodal dysfunction is infranodal block. We call it the infranodal block because it blocks below the AV node. But the ECG, the surface ECG is quite similar between these 2 types of block. but there's some clue in the ECG that we use to differentiate the type of the block. The first type of AV block, or the less severe type, is the first degree AV block. You know that the AV node is in the junction between the atrium and ventricle. So when there is some abnormalities of the AV nodes, it would show in the ECG in the area of the PR. The PR interval here is the represent of AV node. Normal PR interval is around 120 millisecond to 150 millisecond. If there is some abnormality in the AV node, the PR would be longer, like in this ECG. The first degree AV block represent with the longer PR than the usual or the normal people. The impulse can still conduct into the ventricle, but there is more delay in the AV node than the normal heart. And this ECG show the second degree AV block type 1. There is also two types of second degree AV block, type 1 and type 2. This is the type 1. The type 1 of second degree AV block uh, is that you can see that there is some part of the AV node conduction that is still could conduct the impulse from atrium to ventricle. You can see that there's P wave and QRS here, but there is some parts that cannot conduct the impulse from the atrium to ventricle here. There's P wave, but there is a drop of QRS. So you know that there is impulse generated from the SA node and atrium, but cannot reach the ventricle because the QRS is disappeared. This is the second degree AV block type 1. You can see that there is progressive PR lengthening here from the first one here. The PR is around this, and the PR is progressive lengthening because the impulse conduction is delayed. And this is more and more delayed until the AV node is blocked. Here is blocked. Uh, the criteria of the type 1 second degree AV block is the first is progressive PR lengthening resulting non-conducted P wave. The last one is the block P wave. There is no impulse from the atrium into the ventricle. The second one is progressive RR interval shortening. And the RR interval length of drop beats was less than twice shortest RR cycle. You may not have to remember this, but you have to know that there is this type of the second degree AV block, or we can call it a Winky-Buck phenomenon. And there is another type of second degree AV block, a type 2 second degree AV block. This type, there is no progressive shortening, there is no progressive lengthening of PR interval. The impulse would only drop from the atrium to ventricle. You can see that this is P wave without conduction into the ventricle. There is no QRS here. But this one, there is P wave and QRS. So the type 2 second degree AV block is that uh, the impulse could generate to ventricle in the beats before, and after that, in one beat, the impulse spontaneously cannot conduct it into the ventricle. This is the diagram comparing the type 1 and type 2 second degree AV block. I will talk about the type 2 first. You can see that this P wave generates from SA node into the atrium. This one is PR interval or the AV node conduction. This one is atrium conduction into the AV node conduction, and this is ventricular conduction. This is normal conduction. They can conduct through the from the SA node through the atrium into the into the AV node and into the ventricle. And suddenly there's one beat that cannot conduct. This is type 2 second degree AV block. But in type 1, there is progressive PR here, progressive lengthening of PR because the conduction delay in the AV node. Progressive until there is a block in the AV node, and this impulse could not generate into the ventricle. This is the type 1 type 1 second degree AV block, or we can call it Wenckebach block. And with more severe of the AV block, this EKG show the high-grade AV block. The high-grade AV block is that the block that is more severe than the second degree, but it's not reached the complete heart block just yet. This one you can see that there are 4 P waves, but the conduction only conduct one QRS here. This there is still some conduction between the atrium and ventricle in the AV node, but the conduction is rarely occur between the impulse generation from the SA node. This is called the high-grade AV block. And the most severe form of the AV block is complete heart block. You can see from this ECG that the atrium here and the ventricle here, the QRS and the P wave is dissociation. This means that there is no conduction or no connection between the atrium and ventricle. The atrium generate the impulse by itself, and the ventricle also generate impulse by the junctional or by the conduction system in the ventricle itself. There is no connection between them. You cannot see the PR interval. This one is, you see here, the PR interval is not the same in the whole page of the ECG. There is no constant PR interval, so you know that there is no connection between the atrium and ventricle. So this is called third degree AV block, or the complete heart block, the most severe form of the heart block. So we move on into the infranodal dysfunction area. We talk about the nodal block from the first degree to the third degree. And now we are going to talk about the infranodal block, which is the block below the AV node. The block in the bundle of His, in the left bundle branch and the right bundle branch. This is the block in the right bundle branch. You can identify from the ECG that there is a positive R wave, or we call it RS, R prime wave, here in the V1, V2, and V3 leads. And you can see the deep S wave in the V6. This is the right bundle branch block, the block in the right side of the conduction system. Here, the right bundle branch block is blocked in here. And another type of block is the left bundle branch block. The left bundle branch block is there is some deep S wave in the V1, V2, and V3. and there is a positive wave, and there are some in some patients there's fractionate of the R wave in the V4, V5, and V6. This is the block in the left side of the heart. The right bundle branch block, you could find the right bundle branch block in normal population around 15%. But left bundle branch block, you should not see uh, the left bundle branch block in normal heart. If there is some left bundle branch block in the ECG of the patient, uh, we should investigate that if there is any disease in the patient's heart or not. Okay, um, and the third type of the intraventricular conduction blocks is non-specific intraventricular conduction delay. This is called when the ECG on the surface is not compatible with any type of the left or right bundle branch block. The um the ECG is wide and there's some fractionate on the QRS, but cannot compatible with left or right bundle branch block. We would call it a non-specific intraventricular conduction delay. This is caused by the abnormal conduction of myocardium of the ventricle, and maybe some parts of the right or left bundle branch, but not the whole bundle branch. So it would be non-specific, or you cannot locate the block uh, in the heart, which area is causing this type of ECG. So for summary, the location and type of block you have to know from the ECG is that in patients with the bradycardia, uh, is the patient have the SA node dysfunction, and if there is a SA node dysfunction, what type of SA node you would encounter? You would identify the SA node dysfunction by the absence of the P wave. The pattern of the absence of P wave would tell you what type of SA node dysfunction you would encounter. And after that, you would uh, you would see you uh, and for the AV node dysfunction, you would um, you would see from the 12 lead ECG that there would be some type of first degree AV block, second degree AV block, type 1 or type 2, and the third degree AV block. For the His bundle area, the ECG would be similar to the AV node dysfunction. The His bundle area abnormalities would likely cause the 12 lead ECG into the first degree AV block, the second degree AV block, and the third degree AV block, also the same as the AV node dysfunction. And for the right bundle and left bundle branch block, uh, as I have shown before, the ECG would be uh, the wire QRS complex, and as I have shown you before. And if there is some left and right bundle branch block plus bundle of His, you would also see the first degree AV block, second degree AV block, and third degree AV block also. But the QRS complex would be wider and would be the pattern of the right and left bundle branch block. And you can see here the AH interval and the HV interval. This one, uh, this one, we could measure this one. The AH is the interval between atrium to His bundle, and the HV is the interval between His bundle to the ventricle. We could measure this by putting the catheter into the heart, or we call it the EGM, the electrophysiologic study. You will put the catheter into the atrium area, put the catheter into the His area, and put the catheter into the ventricle, and you measure it on the EGM. You will see that there is AH interval for 60 to 125 milliseconds. This is the normal AH interval. And you will see that if in normal heart, there would be the HV interval would be 35 to 55 milliseconds. If these two intervals were prolonged, then there is some abnormals in the heart. If the AH interval is prolonged, there is some abnormalities in the AV node area. And if the HV interval is prolonged, there is some abnormality below the AV node area in the bundle of His and the right and left bundle. So this is the summary of the location of the block from the sinus node area to the ventricle area. And this is the take-home message. There's 4 types of conduction abnormality: the SA node dysfunction, the AV node dysfunction, the bundle branch block, and the intraventricular conduction delay. So this is the first part today. Who has any questions, you can ask me. Or anyone wants me to explain some parts of this lecture again, you can ask me now.
อาจารย์คะ could you mind to explain high grade AV block again?
High grade AV block, okay. High grade AV block is the block that's more severe than the second AV block, because you can see that in second degree AV block, there is some conduction here from the atrium to AV node. The conduction between the atrium to ventricle would not be less than 3 to 1. This means that the P wave, if there is 3 P wave here in the ECG, one would conduct into the ventricle. Not there shouldn't be more than 3 P wave, and the conduction okay, the conduction is more frequent than the high grade. The ratio of the atrium to ventricle is not more than 3 to 1. This means that there is 3 impulse beats from atrium, then one could conduct to the ventricle. But if there is 4 atrium beats and only one conduct into the ventricle, this means that the conduction is more severe, right? Because 4 impulse generation, but could only conduct into ventricle 1. If there is more than 3 to 1 ratio, it is a high grade AV block. You see that this is 4 to 1. The P wave here is in the T wave. It is different from the complete heart block, because it is still some connection here between the atrium and ventricle. If it is complete AV block, there wouldn't be any connection between the atrium and ventricle. But most of the second degree AV block is most of it is 2 to 1, not 3 to 1 is rare. And if it is 4 to 1, it is high grade AV block. Are you clear about this?
เข้าใจแล้วค่ะขอบคุณค่ะอาจารย์
Okay, and is there any questions? Or other type of high grade AV block is that maybe you don't have to see the 3 to 1 or 4 to 1, but some parts of the you see that there is some parts that there are some dissociation between atrium and ventricle, but some are not. Like if the first part of the ECG is likely to be complete, but in the next part there is some connections coming back, and you can call that a high grade AV block also. มีใครถามอะไรอีกไหมครับ If there is no further question, um, I would give you around 20 minutes break before we coming back, and I would have some questions regarding the ECG to ask all of you to identify all the ECG. Okay. เรากลับมาเจอกันประมาณ10:15นะครับโอเคไหมเดี๋ยวจะมีคำถามถาม
ได้ค่ะ
โอเคครับ ส่งสไลด์สอนให้เพื่อนคนเดิมไปนะได้หรือยังเอ่ย
เช็คแป๊บนึงนะคะอาจารย์
ฝากส่งให้ทุกคนด้วย
เรียบร้อยค่ะอาจารย์
โอเคokay so we are going to start the next session is how to investigate the bradycardia and how to investigate all types of bradycardia we have talked about. The outline here is to first is to how to investigate the sinus node dysfunction and how to investigate the cardiac conduction block. As I spoken before, the presenting symptoms of patients with bradyarrhythmia is of these symptoms could be encountered. Uh, Syncope or presyncope may be the most common symptom. Other symptoms such as dyspnea or exertion, heart failure, or confusional states also could be encountered. And this is the step approach of bradycardia and conduction disease. Uh, the first the first thing that you would encounter is the patient come in with the symptoms that suggest it is bradycardia. Then we do a comprehensive history and physical examination to confirm that these symptoms are related to the bradycardia or not. And the first investigation that we have to do is the ECG, the electrocardiogram that we have talked about in the last session. Okay, the first one, the surface 12-lead ECG. And this is a step approach in bradycardia that I have already talked to you from the ECG side to localization of the abnormalities in the heart, the cause, which is reversible or irreversible, and the management of the bradycardia. Okay, so let's come into the first case. This is the 85 years old female without any past medical history. presenting with the recurrent syncope during walk. Anyone can read this ECG to me. This is the easy one. Anyone can read this.
Is it sinus pause?
Sinus pause is not likely correct. Um, you see that there's P wave in the ECG, right? And the rate of the P wave is quite regular, which is what rate is the P wave in this ECG? Can you tell me what is the rate of the P wave?มีใครตอบได้ไหมเอ่ยว่าP wave อันนี้เรทเท่าไหร่ครับ
Around 39.
Okay. The this is the P wave rate 39, which is not normal, right? It is lower than the normal. The normal sinus P wave would be around 60 beat per minute. So this is the sinus bradycardia. If it is the sinus pause, as you have mentioned earlier, most likely the sinus P wave is in the normal range, but there is a drop of P wave more than 3 seconds, and then the P wave would come back, would recover back. But if you see the constant lower rate of the P wave like this, you should read it as sinus bradycardia. So it is sinus bradycardia, and we suspect that there is some abnormalities in the SA node, right? Because the impulse generator, likely the impulse generator can only generate the beats lower than the normal heart. So we are going to see how can we approach this bradycardia. The patient has the symptoms suggest of bradycardia. Yes, it is. She has syncope. So I think there's symptoms that suggest that would cause from the bradycardia. So we do the comprehensive history and physical examination. So we asked, we asked her when the symptoms occur. She answered that um, the symptoms occur while walking, and is it exercise related or not? She answered it may be, and the important question is that is there any current medication that could cause the bradycardia? In this patient, there's no medication at all. She didn't take any medication currently. And the ECG, we have done it already. So we repeat the ECG here, and the ECG is shown here. Anyone can read this ECG. This is the same patient. We suspect that she has the SA node disease, and we repeat again with the ECG, and we see this phenomenon.
Is the sinus
Sinus
pulse?
pause.
This one is sinus pause. This is correct. You see that there's a drop of the SA, the P wave here, and more than 3 seconds, and there's a resume of the P wave, and the resumption of the P wave, the rate of P wave is quite normal, not constant bradycardia. This one is sinus pause. So this is also suggests that she has SA node disease.
อาจารย์ครับ
ครับผม
Why at lead 3 it is showing more like atrial fibrillation?
I think it's an artifact. Artifact is not an atrial fibrillation. You see that if it is atrial fibrillation, it should show in our leads. If there is some abnormal wave in only in some leads, most likely it is artifact โอเคไหมครับ
โอเคครับอาจารย์
um um okay so we okay so in this patient she has we quite sure that she has SA node disease and in lots of patients only ECG could give us the diagnosis and okay we repeat the ECG again uh in this patient can you read this ECG for me what is the abnormal in this patient
Type 2 second degree AV block.
okay and why is it an AV block can you tell me
Because P wave no QRS and
oh,
then
okay
like after that it's come P wave and QRS.
okay so it's so you can see here that there is two PWF right and only one QRS it means that the QRS cannot conduct down into the ventricle and uh, this one is likely a second type 2 second degree AV block okay so uh I just want to tell you that most of the people most of the patient can be diagnosed with a simple tools like ECG but if the ECG cannot tell you there are some patients coming in with symptom of syncope or some symptom that suggests that he or she has bradyarrhythmia but when we do the ECG every time the ECG is normal that doesn't mean she or he doesn't have an abnormal in the conduction system abnormality. We have to investigate further. So there are many tools that could be useful to evaluate the bradycardia. We could on the left side here, we could prolong the electrocardiogram monitoring strategy. We could do Holter monitoring, which is a type of device would attach to you um, for around days to week, and it would give you information of the patient's ECG and the patient's rhythm around the clock. And we could have an external loop recorder. This two Holter and external loop recorder is quite similar, but external loop recorder could be attached to the patient for a longer time, such as weeks to months. We could do a remote home monitoring, which is like a monitor in the hospital, but you could send the patient home and you monitor them from their home, from their daily activity. And the last one is implantable loop recorder. This one is uh, more invasive than the other one. This one is some type of holder that you implant into the patient's skin, subcutaneous, and you leave it there for a month, to 4 years to record uh, their electrocardiogram. This is the strategy that you prolong the monitor of the ECG. And the second strategy that you could do is it's called a provocative test study. You, if you take the history and you have some clue that there are some types of activities that would lead to patient symptom, so you give them this kind of test to provoke the symptoms, and you monitor the ECG between the test, and you would likely to see some some abnormal in the ECG. The provocative test, the most common provocative test that we do is tilt table test and exercise stress test, which is a non-invasive test. Another test that we can do, but we can do it, but we don't usually do it in the clinical setting, but because there is some disadvantage is the carotid sinus massage. I will talk about it later, and uh, to to be clear about this, it is a kind of test that you have to press your finger into patient's internal carotid body on the neck, and you see the change of the ECG, which this can lead to an ischemic stroke. So we don't usually do it in every patient. And the most invasive form and most the most reliable and effective way to investigate the bradyarrhythmia is the electrophysiology study, which is uh, invasive test that you put the catheter into the patient's heart. The first one I'm going to talk about is the Holter monitoring. The Holter monitoring um is like in this picture is the like a small monitor of the ECG. You have the lead attached to the patient chest wall, and you let the patient take this monitor home. The disadvantage of this type of monitor is that the patient cannot take any bath, and the patient usually don't comfortable with wearing it. This monitor could be monitored only for days to week, because after that the patient wouldn't consent to do it, and it is not comfortable to monitor this type for so long in a long time. But this is the most common one that we usually have. And after we have attached for quite some time, like 24 or 48 hours, here in the right monitor here is how we interpret the ECG. It uh, would come into this form, and we can see that in this patient there is some abnormal in uh in his ECG. Yeah. Uh, this is how we interpret it. We would go through some the there is a record for like 24 or 48 hours, and the holder would help us read some separate the rhythm, such as it is a ventricular rhythm, or it is a supraventricular rhythm, or it is normal sinus, and we have to look into the rhythm that the machine read and confirm that it is a true abnormal rhythm. So this is the example of sinus pause from 24 hours monitor. You can see that in this slide, this is a normal sinus rhythm, and suddenly there's a pause in the ECG. This gives us advantage because we can monitor for a longer time. When the patients arrive at the clinic and you do the one-time ECG, it might not tell you anything, but if you prolong the time, you might see something else. The second type is external loop recorder. Uh, External loop recorder uh, is a type of device that you record by your own. There are a lot of kind of it, but this one is called a live call. There is a pad here, which you could put your finger in to the pad, and it would appear as the ECG on your mobile phone or on your computer. And there is a lot of type of external loop. There is single lead ECG. There is 6-lead ECG. You can nowadays there are a lot of technology of external loop recorder. But the disadvantage of this type of recorder is that you cannot see the ECG when you are not putting your hands on the pad. The ECG would only appear when you put your hands on the pad. So the patient needs to have some symptoms or some pre-symptoms before he know himself that he have to put the finger in the pad and record the ECG. If the patient doesn't have any symptom or he or she doesn't know that there would likely to be symptoms, uh, if the patient doesn't record it by him or herself, you couldn't see the ECG at all. And this one, the third one, is the implantable loop recorder. This is just like a small device you insert into the patient's subcutaneous, like you implant the pulse generator of pacemaker, and this would be in the patient for a long time, for many years, and you would record all of the ECG in the whole year. This type of recorder we use when we suspect that patient has a breathy or has arrhythmia, but it occurs not it rarely occurs like when the patient have symptoms for 3 or 4 times a month. You put this in the patient to record uh, a very long duration of the ECG. This is not usually done because it's quite invasive. Here, like I said, you have to implant it in the patient's subcutaneous, similar way to the pulse generator of the pacemaker. Okay, for other investigation, uh, you know that if we detected that patient has bradyarrhythmia or has some arrhythmia, or patient has bundle branch block, we have to investigate the cause of the arrhythmia. Echocardiogram is one of the tools uh, we use to investigate the cause of arrhythmia, because the echo is non-invasive. Patient doesn't have to there is no risk for the patient. So we do the echo to see the whole cardiac function, to see the ejection fraction, to see the valvular function of the patient, to see if there is any abnormalities in the heart that could lead to the arrhythmia. We have to the echo can be used to evaluate the cause of sinus node dysfunction, to evaluate cause of AV node dysfunction. And after that, after we investigate the cause, and we have to see if it is reversible or a reversible cause. Because if it is reversible, we have to correct the cause, and after that, the arrhythmia would be cured. But if it is not reversible, we have to treat the arrhythmia itself. Here is the cause of bradyarrhythmia. The most important reversible cause of arrhythmia is drug. Patients who have antiarrhythmic drugs such as amiodarone, beta blocker, or calcium channel blocker, this type of drug could cause bradyarrhythmia. And if we stop these medications and the sinus rhythm and the normal heartbeats return, we don't have to put the pacemaker into the patient. Other reversible causes such as ischemic heart disease, you can see that lots of people have the inferior wall STEMI, or the occlusion of the right coronary artery, that would lead to complete AV block. If we put the stent in the artery, the AV block would be reversible. So if we know the cause and we think that it is reversible, we treat the cause instead of putting the pacemaker in the patient. And all of these are 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 the reversible cause of bradyarrhythmia. Okay, so we come back to this patient, the patient that has the 85-year-old female without any past medical history, who came in with syncope, and this ECG was sinus bradycardia. And so if you investigate with the non-invasive test that we have been spoken about in previously, and we cannot identify any arrhythmia, or we cannot identify any cause, the next thing we are going to do is the invasive test of electrophysiology study. I am going to talk about the electrophysiology study for the sinus node dysfunction. Like, if these patients, if we do the sinus, if we do the electrophysiology study, or EPS, in sinus node dysfunction, what we would see. First of all, we evaluate the baseline sinus cycle length. We see if what is the rate of the sinus, and we evaluate the sinus node recovery time and corrected sinus node recovery time. I will explain it to you in the next slide. Don't worry about this one. Just remember the name, the sinus node recovery time. It is the meaning of it is that you see you trigger something to cause the sinus pause, and you see how many milliseconds the sinus node would come back or would recover. The sinus node recovery time is the duration from the last atrial stimuli to the first returning of sinus rhythm. This one is when we cause the sinus pause by doing the atrial stimuli, by pacing the atrium fast, and you stop pacing. This would cause the sinus pause, and you see if there is any returning of the sinus node and how fast is this returning. The protocol of sinus node recovery time is that you stimuli or you pace from high RA with a cycle length of 300 to 800 milliseconds. The different cycle length should be repeat 30 seconds, and that you see the duration from the last atrial stimuli to the first returning of the sinus beat, and you see how long it is, what millisecond, how long the returning cycle length it is. The normal value of sinus node recovery is less than 1,500 milliseconds, and we use the corrected sinus node recovery time because this one would give you a more accurate evaluation. It is a sinus node recovery time itself minus the sinus node cycle length. The correct sinus node recovery time is less than 525 milliseconds. Okay, so this is how we do it. This is the intracardiac electrogram. Oh, I have to ask first that is there any lecturer teach you about the intracardiac electrogram? มีใครสอนเรื่อง EGM หรือยังครับ
เดี๋ยวแล้วค่ะ
เดี๋ยวแล้วเนาะโอเคจะได้สอนจะได้พูดต่อได้ไง Okay, so we put first of all we put here three of this is the surface ECG, and we put the catheter in the RA. His proximal, his distal, his mid, and his distal. Sometimes we just put the his catheter in, only one his catheter, and we put the RV catheter in. And now we paste from the RA, paste from here with a fast cycle length. We paste the fast cycle length for some times, and we stop pacing, and this would cause some pause in the sinus node. And we measure the sinus node recovery time from the last atrial stimuli to the first atrial beat. Here is 102 1200 milliseconds, which is normal for sinus node recovery time. The sinus node recovery time would be less than 1500. And we also could calculate into corrected sinus node recovery time by using this number minus with the normal cycle length. Okay, here is another example. You pace from the atrium and you stop, and you see you measure from the last atrial stimuli to the first sinus beat, and you have sinus node recovery time of 1167 milliseconds. And you are going to calculate the corrected sinus node recovery time by minus this number to the normal sinus cycle length of 1045, and you have 122 of corrected sinus node recovery time. So you use this type of protocol to test if the patient has sinus node dysfunction or not. If the patient has the sinus node dysfunction, the sinus node recovery time would be prolonged, because when you pace a lot and you knock down the sinus node, it takes a longer time than normal people to recover. Okay, for the management of sinus node dysfunction with symptoms and a reversible cause, we would put the pacemaker in the patient, which the first choice of pacemaker would be dual chamber pacemaker. We have we have talked about this from last session, so I'm not going to go into the details of this one. Okay, so this is the second case. The second case is a 25 years old male without any past medical history. He presented with abnormal ECG without any symptoms. You have read this ECG before. It is likely an AV nodal block, and likely it is a second degree AV block type 2. But he doesn't have any symptoms at all. What would we do next to this patient? So let's see. We have to do a comprehensive and history and physical exam. And we didn't find anything. There's no symptom. He could exercise. It is not related to any exercise. There's no abnormal in his exercise. And he has no current medication that could cause this type of bradycardia. So the next thing about the AV nodal dysfunction is that we have to see that it is which level of AV nodal block he has. He has the AV nodal block inside the AV node itself, or he has a block below the AV node. in bundle of his, or he have both right bundle branch block and bundle of his block, or left bundle branch block plus bundle of his block. In this patient, we see that there is a drop of QRS here. Okay, we confirm it's an AV block, and we see this one on the lead V1. There's some kind of a fractionate wave in the V1, and we have see that it is some deep S wave here, and we are not sure that maybe this patient also has right bundle branch block also. Maybe he has both a block in AV node and right bundle branch block, or he has a block in the his bundle system or not. How can we know that for sure? So we're coming back to this location and type of the sinus node area. So we see that in the AV nodal block and also in the infranodal block in his here, we could encounter all the first degree AV block, the second degree AV block, and the third degree AV block. And from the 12 lead ECG, we cannot be 100% sure that which type of the block we encounter. We have to investigate more to see any clue of the level of the block in the patient. So what we can do to distinguish between the AV nodal block in the AV node itself and the lesion under the AV node. We can do the non-invasive intervention to determine the size of block. The intervention that we can do, the first one is to inject the atropine. If it is the AV nodal block, the conduction would be improved. Like if it is 2-to-1 block, 2 atrium and 1 contact ventricle, we inject the atropine in the patients. If it is the AV node conduction abnormality inside the AV node, the ECG should be improved into 1-to-1 or into less degree of AV block. But if it is infranodal block, the block below the AV node in the area of his bundle or the bundle branch, the ECG would be worsening, such as if it is a second degree AV block, it could be worsening to high grade AV block or complete heart block. Second intervention that you could do is let the patient exercise. You could put the patients into the treadmill exercise, or you could uh, uh, make the patient to walk in the ward and see if there is any improvement or worsening of the severity of the AV block. If the exercise could improve the level, improve the severity of the AV block, such as it is second degree AV block, it coming back to first degree AV block, it should be the disease in the AV node. But if it's worsening, it should be the disease below the AV node. And the last intervention is the carotid sinus massage. This is vice versa than the other two intervention. If you do the carotid sinus massage and the AV block is worsening, it should be the lesion in the AV node conduction. But if the AV block was improved, it should be the lesion below the AV node. So this is the exercise stress test that we can use to differentiate the level of AV nodal block. Uh, if in this patient This is the ECG of the patient with here is the right bundle branch block, and with the right bundle branch with sinus rhythm with right bundle branch block, and we do the exercise test, and the ECG appears to be like this. You see that the conduction of the conduction is worsening. You see that the P wave is not associated with the QRS. You could tell that it is the block below the AV node because it is worsening with the exercise stress test. So the benefit of exercise stress test in the AV node dysfunction is the first benefit is that we could evaluate for the symptoms. If the patient coming into us and they told us that there is no symptoms at all when he has a bradycardia, that might actually not the real thing, because patients might be sedentary, might not they might not exercise a lot, and if you do the exercise stress test, you put the patient in the treadmill, you could see that there are really some symptoms during the exercise that could confirm you that he actually has a symptom, not asymptomatic. And you could also benefit from the exercise test by differentiate the size of block between inside the AV node, the nodal block, or below the AV node in the his bundle region, or infranodal block. And the most invasive way to evaluate the size of block in the AV node dysfunction is to going into the heart of the patient to measure the baseline between the atrial and his interval and between the his to ventricle interval to differentiate between the nodal block and infranodal block. As we speak before, we put the catheter into this one is the CS catheter to the high RA to the CS to the his area and to the to the RV, and we measure the the AH interval and measure the HV interval to see which level of block it is. If it is nodal inside the AV nodal block, the AH interval would likely to be prolonged more than 125 milliseconds. But if it is below the AV nodal, the infranodal block, the AH interval would be normal, but the HV interval would be prolonged more than 55 milliseconds. Here is the intracardiac electrogram to measure the AH and HV interval. This one you can see, this one is A. This is A because this hollow catheter is called the hollow catheter. It's the atrium catheter with many leads. It's called the hollow catheter. So the signal from the hollow is the atrium signal. This one is A. And this one is ablation catheter, but in this patient we put the ablation catheter into the his area. So we see that this is his bundle signal and this is ventricular signal. How can you know that it is ventricular signal? Because it is the same signal that it comes timing in the same time of the signals in the RV. This is the ventricular signals. And we measure the duration between the A to his and to his to the beginning of V. And we would obtain the AH interval and the HV interval. This is also the EGM. This one is atrium. This is his, and this is V. So you can see that this HV interval is very prolonged. And for this B, there is A in A, there is his, but there is no V at all. It means that there is some block between the HV interval. So the signal could come from the atrium, the sinus to atrium, and to the his, but cannot reach the ventricle. There's some abnormalities between the his bundle and the ventricle. So this likely the site of block is likely to be infranodal between the his bundle and the ventricle. So from this electrogram, we could tell that it is infranodal AV block. This one also, we see that there's a his and a very prolonged HV interval. And another signal comes in, there is an AH, but there's no ventricle signal. So it must be something that block the signal from the his to ventricle. And after we have after we know that it is a V block from the 12-lead ECG, we investigate that uh, investigate and we know that the site of block, where the site of block is, we also have to investigate what is the cause of a V block, and is that the cause that reversible or the cause that is not reversible, and also the cause of AV nodal block is quite the same as the SA nodal block. The most important cause is medication that patient has. This cause we have to investigate as same as the sinus node dysfunction. We could do an echocardiogram. We have to review the medication history. We have to investigate further to see the cause is reversible or not. Okay, and this is the echocardiogram. We also do it in an AV node dysfunction. And also, if it is AV node dysfunction, it is more likely to have some types or some rare disease that could cause AV node dysfunction, such as amyloidosis. If we suspect those disease, we can also proceed to do a cardiac MRI to confirm the cause of the AV node. This is the example of the cardiac MRI. And further investigation to see the cause of AV node dysfunction. If we suspect that patient has some abnormal myocardial disease, we can also proceed to do the cardiac biopsy. And in some cases, if there is a rare myocardial disease, we might the pacemaker implantation might not be enough for the patient. In some patients, they might require dual chamber ICD. You don't have to remember this, but I just want you to know that in some type of bradycardia, which there is a cause from some rare disease, pacemaker might not be enough for the patient. The patient might have to be implanted with the AICD, in which the AICD have both pacemaker function and the shocking function. It's not enough because some of these disease can cause bradycardia, and also in the same time, This disease can cause ventricular tachycardia or the ventricular fibrillation. So after we know the cause of the bradycardia and we know it is reversible or not reversible. If it is reversible, we go ahead to treat the cause. And if it's not reversible, we have to consider other things such as hemodynamic instability. You have to see if the patient is stable or not. Patient has alteration of mental status. Do they have sign of shock? They have ischemic chest pain or not? They have heart failure or not? If they have this kind of symptoms, we have to treat them emergency or urgently. We may give them an atropine, a dopamine, or epinephrine first, and after that we have to put the temporary pacemaker in the patient before we proceed to the permanent pacemaker, because these things can be done quicker than go ahead to do the permanent pacemaker. And also we, at the same time, we should correct the cause if there is any reversible cause of bradyarrhythmia. Okay, for the take-home message of this session, we have a lot of investigation now today, but the comprehensive history and physical examination is still a crucial way to diagnose and to evaluate the patients with bradycardia. The ECG is the simplest investigation, but the most important, and it is a powerful tool to investigate the bradycardia. So all of the patients suspected bradyarrhythmia should be start with the electrocardiogram or the ECG. And the proper investigation that I have mentioned before, there are lots and lots of investigations, lots of tools, lot of non-invasive and invasive types of investigation. The proper one we pick up is depend on the history and depends on uh, what we suspect in the patient, and we pick up the proper investigation. We usually not doing it all of the investigation. We usually do it for only one or two types of tests, and after that we diagnose patient and we go ahead for the treatment. Okay, so this is all for uh, this session. So anyone has any question regarding of this lecture?
อาจารย์คะการที่มัน management ด้วย cardiac biopsy มันช่วยยังไงเหรอคะ
อ๋ออันนี้คือสมมุติโอเค in some case with bradycardia, when you go back to the cause of bradycardia, you could see that there is some type of infiltrative disease here and inflammatory damage here. I will give you example. If there is some an 80 years old student coming into your hospital with an AV nodal block, and you know that it is not common in the younger people to have any kind of bradycardia, right? So you suspect that there might be a cause to this patient to have bradycardia, and so you go ahead to do some kind of test like echocardiogram, and you see that the patient uh, systolic function, LV systolic function is not good. So you suspect that this patient might have myocarditis or some kind of inflammatory in the myocardial disease. But from the non-invasive tests such as echocardiogram or the cardiac MRI, sometimes you cannot differentiate the type of inflammation. You have to do the cardiac biopsy to obtain the myocardial cells, and you send it to the pathologist to see if to see that the tissue, what's wrong with the tissue, what the pathology of the tissue, and after that you you can you can have the diagnosis from the tissue it เราทำเพราะว่าบางที non invasive test มันตอบไม่ได้ว่าคนไข้อะเป็นอะไรกันแน่เราต้องแบบไปตัดชิ้นเนื้อออกมาดูอะครับokay is it clear
yes ขอบคุณค่ะ
okay anyone have any questions I have only 2 of this lecture so we have quite some times you can ask meใครถามอะไรไหมครับ Okay, if there is no further questions, I think this is all for today. Okay, and we have finished earlier than the schedule, so you could have a lunch break early. Okay, so that's it all for today. Anyone has any further questions, you can ask me now, or we could end the lecture today. งั้นถ้าไม่มีใครถามก็วันนี้จบแล้วนะครับ ก็ขอบคุณมากนะครับ
ขอบคุณค่ะ
ขอบคุณอาจารย์มากเลย
งั้นเดี๋ยววันศุกร์หน้าเจอกันอีกทีหนึ่งเรื่อง AV NRT กับ AVRT นะครับ เดี๋ยวจะพยายามส่งสไลด์ให้ก่อนนะครับ
ขอบคุณอาจารย์มากๆเลยค่ะ
โอเคครับ
ขอบคุณค่ะ